Hi, good morning. This is Kate Birch, and this is a presentation on the long-term homoeoprophylaxis study in children in North America that was sponsored for the last 10 years from Free and Healthy Children International. And this presentation was first presented in New Delhi, January 10th, 2020, at the HP Worldwide Choice International Conference on Homeoprophylaxis. So today I want to talk about review our study, part 1, which was the factors contributing to the successful completion of sequential dosing of diseased nosodes. And part 2 is looking at the safety of homeoprophylaxis, review of immunological responses and effects on general health outcomes. I was the principal investigator, that's Kate Birch. Sue Sandin was our data collector. Sarah Damlow was editor and chief data committee. And Kim Lane was our medical advisor. So the method, we registered children between April 1st, 2009 and December 31st, 2014. They were all registered under the supervision of a homeopathic practitioner trained in HP. Once enrolled, they were to undertake a self-administered 44-month program for 8 different diseases to be completed within 50 months according to a previously set schedule. Each family was equipped with the HP program booklet, you can see that on the left, that included homeoprophylaxis record and HP supervisor contact information. There was a written comprehensive overview of the program, written instructions on how to complete the program, and a journal to note remedy responses in there. There were 3 questionnaires to be submitted at 3 different stages of the program, and they also got their remedy kit. The research parameters included informed consent, data protection, ethical considerations for disease exposure, inclusion-exclusion criteria, data collection, which included the socioeconomic data of the family, nosode remedy response documentation, and initial and final health outcomes. We did not have a control group, and there was no blinding in this research. Standardization of treatment means that every child was to participate in the program as we had laid it out. Could be changed if the child was sick or if there was actual potential disease exposure, and it could be modified to the age of the child like that, but for the most part, everybody did the same thing. We developed an adverse event reporting system to track whether there were any adverse events, and the exit strategy is that a family could leave at any time, and if they opted for conventional vaccination, they could do that. Our cohorts were the total registered number of boys and girls, number of unvaccinated and previously vaccinated children. They were compared as to age of entry into the program, how many prior vaccines received, socioeconomic standing of the family, and reasons for incompletion of the program, and accessibility to HP supervision and regional differences in completion of the program. So within the socioeconomic parameters, we looked at family type, whether it was married, single, step, so on and so forth, yearly income, highest education of parents, medical coverage. Were these factors part of how or why families could complete the program or not? The choice of education for the child, that would be public or private school, food types, and the amount of TV watched, just to kind of get a profile of who is looking for HP and who is more likely to succeed. So the total number registered was 682. Of those, 475 were unvaccinated and 207 were previously vaccinated. More than half we had no contact with because we had a passive submission system of paperwork. So of the 339 total respondents, 126 completed the program, and 62 of those completed within 50 months. And this precipitous drop-off of participants led us into understanding more about, how much education a family needs up front, what kind of supervision support they need, and to be wanting to complete the program, and so on and so forth. The age groups of registrants, the largest percentage were in the 0 to 6 months of age, so newborns, and the second largest were 12 to 24 months. We did have all the way up to 10 plus, and then we looked at percentages of who was most likely to complete, and certainly the younger children, parents of younger children were more committed to the progress. And the same group, the 12 to 24 months old, they were also, a higher percentage of those were able to complete. We looked at the number of previous vaccine disease doses per child at registration and at various stages of the program. There were a total of 3,433 vaccine disease doses given to all the children at registration. So we said here again, 469 were unvaccinated. One DTaP vaccine equals 3 vaccine disease doses. That's how we calculated these numbers. And we can look and see that actually there were a large number of children who had received 24 to 41 doses of vaccines. And this tells us that, the parents had done a number of vaccines but still felt incomplete in their process for the children. You can see also that a number had done 1 to 4 vaccines, and then they came to homoeoprophylaxis. And if you look at the percentage of, again, in the complete, so yes, maybe they had done a number of vaccines, but they were also more committed to completing the program. This is one of the tables of the Socioeconomic, and we want to point out that middle income earners were the highest percentage of registrants, and again, the highest percentage of those who completed in 50 months. And higher earners, even though at the beginning there was like a high percentage of registrants, but many of them withdrew, so we don't necessarily understand what that is about. Basic socioeconomic responses were compared similar levels on all degrees. Here it is that the university graduate, so those who registered, so the HP was appealing to more educated people. We could potentially say that's why there are higher earners, except for it was those college undergraduates, maybe with a young family, also managing this whole, both parents or one parent going to school. They were more likely to complete the program than others. And then we look at the choice. It was originally more those people who chose private school versus those who are more likely to complete were actually attending public school. And the biggest variable was actually the amount of TV watched. So those who were more likely to complete watched less TV. And that must be a time management issue, because that was the #1 reason why people withdrew from the program. There were also, in some instances, too many responses to the HP doses, and parents had confusion about what to do with those responses, or didn't have enough societal feelings. Societal support means that parents often chose HP in the isolation, even within the family structure, like husband and wife disagreed, or in the extended family, that these parents were opting out to do something that was out of the societal norm, and didn't understand the program was another reason. But our conclusions from part 1 was that when middle-class families of unvaccinated and previously vaccinated children understood what they were doing and were supported by competent practitioners, they would successfully complete a self-administered HP program. So this is the actual HP program. It shows the diseases that we have and the protocol that we laid out. There were 3 stages where they would submit questionnaires, and then we would track, how many doses of each were given. And these same 8 diseases are repeated in 3 different dosing series. So when we look at these dosing series, we can count how many numbers of dosing series per disease were given and how many individual doses. So the 200C listed once is 1 dose, the 200C listed twice is 3 doses. And then we looked at the responses recorded and the relative percentage. In all diseases except for pertussin, it was the second dosing series that produced the more responses. But then as we go through the protocol, you'll see that the responses rates drop. And the very last dosing of the morbillinum for measles shows the lowest amount of responses. And we have some theories about why this might be, but was it that pertussin was given first and the first single dose was given to many newborn infants, and so there was a larger immune response there? As the child aged, through the cumulative effect of these immune responses, they were getting less and less immune responses, showing that the health was getting stronger. There was no longer the need for the immune responses. There's a lot of different ways that we can look at that information. Here are our numbers. There were a total of 9,333 individual doses given. And again, the highest percentage of responses was in the 200C series, and that's for all cumulative of all diseases. So not all dosing series were given. So they're even with the submitted paperwork, if they not all doses were recorded or documented, so we didn't have the information of all doses given. And 35 of the 126 who completed did not provide us a prophylaxis record, so their numbers are not included in this data. All of this is to say, from all of the doses given, not a single adverse event was reported. According to the National Institute of Health Guidelines for Research on Human Subjects, an adverse event is a death or life-threatening experience, inpatient hospitalization, persistent debility, or congenital abnormality or birth defect. The common symptoms were cold, flu-like immunological responses with attendant mood alterations, runny nose, sore throat, coughing, slight fever, high fever. All of these are common symptoms responded in the first 12 to 48 hours of the HP dose or dosing series. We do have a complete individual symptom presentation in our other research that's going to be published that shows the actual clinical indications for the homeopathic use of that remedy. And these are general health outcomes. There's a number of things to look at in this chart. What we did look at was the incidence on initiation prior to, so on registration of unvaccinated, and then those that completed in 50 months, and then previously vaccinated, and those that completed in 50 months, and then compared to national incidence. So you can see across the board that the number of children, except for in seasonal allergies, food allergies, and eczema, the incidence is below national rates, even at the outset and at the end. These other ones are above national rates, so either the sources for these national rates are incomplete, or that there was something about our group that going into the program had worse health off than the national rates. But I want to point out an interesting thing is, so the previously vaccinated recipients were older, but in all parameters, the incidence of these conditions dropped from beginning to end, so that we could say that homoeoprophylaxis actually improves the level of health of previously vaccinated children. In those that were unvaccinated, as we saw that the majority were between 0 and 6 months of age, where usually these children don't have chronic disease presentations, that as they got older, some of those susceptibilities of the child shows up, and you can see that in some instances the incidence does go up, but overall still lower than national incidence. And then looking at the neurologic symptoms is across the charts, they are lower than all national incidents, and in some instances got better, and some was just there. So what we want to say from the conclusions of part 2 was that HP offers both unvaccinated and previously vaccinated children a low-risk immunization method that improves general health outcomes, and improved health outcomes in previously vaccinated suggests that HP may be of benefit after previous vaccination. Thank you so much. Thank you for listening. We invite all questions that you have, and to learn more from freeandhealthychildren.org.